Okay, so good evening, everyone. My name is Omar Elboraey. Tonight, this evening's teaching session is regarding a case with what's called respiratory arrest and shock. Dr. Mohamed Sharif is going to present it to us. So it's gonna be an open discussion. So everyone is welcome to express their opinion and what could have been done better, what could have been done, what you think is better, what you think, what you've learned, and what could have been done better, what's done right, and we'll see. Thank you very much.
Thank you. Okay, guys, let's start then. Okay, so as you all know, like you will meet mysteries in your medical practice. One of my consultants used to say that you shouldn't lose a battle with a mysterious patient. That was his own philosophy, because he thought that if you are dealing with something that you think you have seen before, then you would be depending solely on your experience and on like what we call the pattern recognition method of diagnosis. But when you're dealing with a mystery, then you start opening your textbooks and start consulting and taking opinions of other people. So his philosophy was that mysterious cases have better prognosis. Don't know if you would agree or not. So let's see the case. This actually was I can't hear you. What did you say, Omar?
Sorry, that was I know he's just.
Okay, fine. So this is a real patient. It was seen like 2 years ago, and I'm saying this to make you know that this was in the middle of the pandemic. So the context of the case is very important, because like there was a big trend of that everything is coming is COVID till proven otherwise, and we'll come back to this later. Okay. So this was a 58-year-old lady who lives alone, and according to the relatives who brought her to hospital, she had no medical history at all. She presented with gradual and progressive decrease of conscious level over a week. There was no history of any other neurological, respiratory, abdominal, or constitutional symptoms. And there was only a history of non-specific fever in a family member like a couple of days before the presentation. So on examination in the ED, this patient's airway was patent and clear. She had spontaneous regular breathing, respiratory rate normal, saturation normal on room air. She had bilateral equal air entry with no added sounds. Her heart rate was 70. Only her blood pressure was on the borderline on the lower side, 90-60, and her capillary refill time was a bit prolonged at 3 seconds. Her peripheral pulses were felt. There was no murmur, no gallop, and no distended neck veins. Her Glasgow Coma score was 10. She had eye-opening to pain, localizing to pain, and she said only words, and she had no signs of lateralization. Her pupils were bilaterally round, reactive, and regular, and her reflexes were weakly elicited symmetrically with bilateral flexor plantars and no signs of meningism. She had no apparent rash, bruises, bleeding, orifice, or scars, and her temperature was 37. So, any comment till the moment? Hello?
No, nothing to point to what you gonna work after that. Like
Okay.
it's maybe mainly CNS disorder so far. That's what I'm thinking about.
Okay. Then, like now, all what we have is some hypotension with prolonged capillary refill and some decreased conscious levels. So we started by giving IV fluid bolus, okay, and we did a brain and chest CT. Chest CT at that time was done as a routine because, like, we considered COVID with almost any patient that presented to the ED, whatever the presentation was. So we did brain and chest CT scans, and before we have any official report, we saw the CT and it was provisionally unremarkable. So we had a urine catheter inserted because she had this low blood pressure, and she initially she had good urine output. Then we started labs. I think you may be astonished that all these labs were done, but at that time, like in that facility, we did extensive lab workup for any critical patient. So the patient's full blood count was normal, renal functions were normal, her liver enzymes were a bit elevated, D-dimer also slightly elevated, cardiac enzymes normal, electrolytes normal, except for magnesium and calcium, both were slightly depressed. Her CRP was elevated and procalcitonin was elevated, and bilirubin normal. And then we had this TSH was normal. FT3 and FT4 were low, both low. If you wonder why we did this thyroid profile, it's also in that facility we did thyroid profile for any patient who was above 50 years. That's why we did it from the start. Coagulation profile a bit prolonged, and her blood gases, she had discompensated metabolic acidosis, mainly lactic acidosis, and her virology was negative. By this I mean BC and HIV. Okay, so at this moment, like, our main issue was that this patient has some sort of sepsis, and then we started sepsis bundle. So this patient, we had blood and urine samples for cultures, and her first dose of antibiotic was given in the ED. Then we sent some confirmatory samples of these labs, and then we maintained the patient on fluid and on fluid maintenance. Then this patient was transferred to the ICU. When she was in the ITU, then her blood pressure dropped and became unrecorded. So this was even after she had the fluid bolus, and she became anuric. So we repeated the ABCDE assessment, and it was almost the same, apart from the idea that her blood pressure is unrecorded, her capillary refill became prolonged, and otherwise it was the same. Her temperature also spiked to 40 degrees. And then also her metabolic acidosis worsened. Her bicarb dropped to 14. Her lactate rose from 23 to 47. So till now, how do you think about the case?
Looks like there is some source of shock, but what kind of shock that needs differentiating? Probably septic shock because of the high inflammatory markers and fever, despite it doesn't fit with the presentation, which is just low GCS for a week, nothing else. But that's my provisional understanding so far.
Exactly. So mainly this patient has a shock state. What we have is the unrecorded blood pressure and urea. So this is a shock state. the other part is that her GVP is not elevated, so we are not talking about cardiogenic or obstructive shock. And also we have high increased inflammatory markers, and we have fever and an acute onset of presentation. So we are almost talking about a septic shock rather than any other kind of shock. However, till now we don't have a focus, like a specific focus of infection. Anyway, a patient like this will go into two ways at the same time. We'll seek stabilization of the patient, and we'll also seek to find a diagnosis for the patient. So, seeking stabilization of this patient, we inserted a central venous catheter and started putting her on vasopressor and norepinephrine, and we corrected the electrolyte imbalances that she had, and we reached a high dose of norepinephrine, and we couldn't maintain blood pressure, so we started IV hydrocortisone, a stress dose to maintain try to correct or control the shock state. And seeking the diagnosis now, this patient was put in isolation because we were suspecting COVID. Still, the patient didn't present with any respiratory, but at that time, like we were extremely afraid of COVID at that time. That's why she was put on isolation, and COVID lateral flow test was done, and it was negative. Okay, so we sent a PCR to make sure that it's not missed COVID, and we had a CSF sample as well, and the analysis was normal, so we didn't do a culture. Her urine analysis was normal, and later on we'll know that even her cultures will be normal, like her urine and blood cultures would be normal. Okay, and we did an echocardiogram and it was normal. So now we're dealing with septic shock that we don't know where sepsis is. So again, COVID PCR came back negative, and you remember the confirmatory samples that we did for the initial labs, they came back as follows. So TSH is still normal, FT3 and FT4 both on the lower side, like they are borderline on the lower side. So for us, like, this was strange to find these thyroid functions. So we suspected at this stage, we suspected this patient may have a central hypothyroidism issue. So we suspected central hypothyroidism and started the patient on levothyroxine. In that facility, we didn't have any IV levothyroxine, so we had to put her on oral levothyroxine, but she was shocked and her digestion was impaired, so we had to give her rectal levothyroxine. And this was at higher dosage, like at double or triple the oral dose. At that point also, the brain CT, we had the official report for the brain CT, and it said that the patient had a ballooned sella turcica with fluid density. So this also was going with the idea that she may have a central hypothyroidism. So after we started the levothyroxine, then shock state started to improve, but still conscious level didn't improve. Okay. On the following day, she became profoundly hypoxic. So this is the second day of admission to the hospital. She became profoundly hypoxic and resistant to all oxygen delivery devices, so she was intubated and mechanically ventilated. We did a follow-up CT scan of the brain and chest, chest, of course, to know why she became so hypoxic, and brain to make sure that her conscious level is was not, for example, some sort of stroke or something. And again, both came back unremarkable. So let's skip this at the moment. At this point of time, what do you think about the case?
I have no idea, to be honest.
Excuse me, have you done? Excuse me, because I'm now doing the endocrinology quotation for myself. So you told me like you're suspecting central hypothyroidism. So have you done full pituitary profile?
We will do it, but we haven't done it at this stage. But we did it afterwards. Yeah.
I think, yeah, maybe this has been should have been suspected earlier. So once you suspect or start treatment for central hypothyroidism, then your next step should be like checking the other pituitary hormones. One of them should be the ACTH, and check the serum cortisol, because of the serum cortisol. If it's low, this will explain the whole shock status and the whole problems. Because if it's pan-hypopituitarism, then the treatment should start with hydrocortisone first. But you've already started that beforehand, right?
So you're right. You're right with this, and as you said, we have already started the patient on stress dose hydrocortisone. So this is like 200 to 400 milligrams per day. So even if she was hypoadrenal for any other reason, that would be sufficient. Yeah. And you are right, of course. The next step would be to search for the rest of the pituitary hormones.
What I'm not getting yet is why she is profoundly hypoxic. Even if it's pan-hypopituitarism, what's the relation between that and the respiratory failure?
Yes, exactly. So now what we know is that this patient is hypothyroid, and this explains why she had this resistant shock state, and it started to improve after the patient was given hydrocortisone and levothyroxine. Still, we have the other issue, which is why she is hypoxic and why she is why she has this disturbed conscious level. Okay, so, and again, we had this brain and chest CT follow-ups, and they both were normal. So at this stage, what would you do, regardless of these hypotheses? What would you do for management of the patient? This is the second day of admission, and the patient became profoundly hypoxic, and she wasn't on admission. And you don't know why she is hypoxic, and you don't know, or you don't know for sure why she is shocked.
In our ICU, we use the cardiac output monitoring devices, and this can explain to you the type of shock that she's having. I know that the echo is normal, and at some point urine output was okay, and it looks like an afterload issue. But it's dynamic changes of this will give you a dynamic monitoring of the cardiac output, and also can give you an idea about why she's profoundly hypoxic, because yeah, hemodynamics and respiratory system are linked together. So if she's not well perfused for some reason, she might be hypoxic for the same reason as well. Mm-hmm. So that's my thinking, and what we probably, if she is with us in our ICU, this would be the next step, is to put her on the cardiac output monitoring and see what's happening.
So that's great, yeah. And actually, I didn't include this in the PowerPoint, but at this point, we did a follow-up of echo, and it was the same thing. And we also like do this assessment for fluid response using the echo, so using the straight leg raising test, or giving a fluid bolus. And she was already like fluid unresponsive. She was at that time already filled with fluid, so she didn't need any extra fluid. And also we have taken a sample from her, like a central blood sample, and she was really hypoxic. It wasn't just that she was hypoperfused and peripherally hypoxic, she was centrally hypoxic as well. It was true hypoxia, I mean. So at this stage, we thought that maybe she had a massive pulmonary embolism or something. But yes, we know that this is just her second day in the hospital, but we said that maybe during the previous week she was she had decreased mobility, or maybe no mobility at all. So we don't know exactly about the week before she was admitted. So we started her empirically on therapeutic anticoagulation for a suspected pulmonary embolism, and also we started IV remdesivir for suspected COVID infection. I know that this use of antiviral may be debated, but that was the protocol in this facility at that time.
Sorry to interrupt you. Hi.
Okay.
Sorry.
Hi.
I'm just a quick. Sorry to interrupt you. Just a quick question. So the lady, when she came, she was saturating well in room air, and her chest was clear, and then she had a CT chest, which was fine. But then she desaturated suddenly. Did she have a repeat CT or repeat X-ray at least?
Yes,
after desaturation.
Yeah, we did a follow-up CT chest, and it was unremarkable, totally unremarkable.
After the desaturation, you mean?
Exactly, yeah.
Okay, thank you. So there was nothing on the CT, nothing on the X-ray.
Sorry, what? What did you say?
After desaturation, there was nothing on the CT or the X-ray after the desaturation event.
Yes, exactly. There was nothing at all on the CT.
Okay, sorry to interrupt you. Go on.
I have another comment, Mohammed. Sorry. I think the rationale behind the anticoagulation was not very fulfilled, and it's also, from my point of view, is very risky at this stage, for a reason that you have already discovered that this lady has manifestation of a failing pituitary gland, and the official CT report did tell you that there is a ballooning at the cilia turcica. So she might be bleeding in her pituitary with a pituitary apoplexy, and now are giving her anticoagulation as well. I think it's no, it's a wrong decision for my opinion. Unless you rule out the pituitary apoplexy as a cause of a failing pituitary, you shouldn't start anticoagulation.
So actually, the CT record said that the ballooning was of fluid density. It was not. So they analyzed the density of the tissue in the balloon, and it was fluid, just fluid, no bleeding.
Okay. So it was considered that what I mean.
Exactly. Yeah.
Okay.
So again, as I said, like we treated her as suspected pulmonary embolism and suspected COVID, but we sent a full respiratory viral panel, and we sent also COVID antibodies. Like we were at that time. That's why I told you that this was in the middle of the pandemic. We were very obsessed with COVID because there were a lot of logistics behind any COVID diagnosis at that time. So if the patient is COVID and we are putting her in a non-COVID area, that would lead to a big logistic problem with relatives and authorities. That's why we were very obsessed with COVID at that time. So we sent COVID antibodies, and we had the IgM negative. The IgG was positive. So again, this is telling us that she had a previous infection. It's not acute COVID by any means now. Yeah, this is the crux of diagnosis now. So do you have any comments before I tell you what we discovered? Most of you have already seen it on the screen.
No. Reveal the mystery, please.
Okay, so the respiratory viral panel came back positive for influenza A. And for us, at that time, it came back like a shock, because we haven't seen any patients with influenza for maybe a year or more than a year. We were very, very, very obsessed and busy with COVID. So it became as if there was no influenza at all for these for these several months, like from the beginning of the pandemic till that time. We have never diagnosed a case of influenza. Everything was just COVID. So this was some sort of shock for us. Tell me if you were in our unit at that time and you saw this positive influenza A PCR, do you think it would have been a shock for you as well, or we were just not exposed enough?
I think I would take it as hospital-acquired influenza rather than the primary diagnosis, because it might explain the respiratory deterioration, but it doesn't explain the full picture.
Yeah, it doesn't explain the shock state, but we have already diagnosed before that the patient was hypothyroid.
You mean mixed diagnosis?
Exactly. It may be a mixed diagnosis.
Maybe, yeah.
So since we have this positive PCR for influenza, we started oseltamivir, and conscious levels started to improve slowly, and hypoxia started to improve as well. Over the following days, vasopressors were weaned, conscious level improved, and mechanical ventilation was weaned. This was very good. I'm sorry, guys. Just give me a second. Hello.
Yeah.
Yes, I'm back.
Okay.
Sorry for the interruption. Yeah.
No, that's all right.
Okay. So as I said, after the patient had now the levothyroxine and oseltamivir, the patient started to improve from both, or now it's not just two, from the three problems that she had: the conscious level, the shock state, and the respiratory failure. Let's go now for the surprise. Yeah, she became fully conscious later on, and the surprise that she told us that she had a pituitary adenoma excised 15 years ago, and she didn't attend for any follow-ups because she was completely asymptomatic since the operation. As I said before, like we did the comprehensive endocrinal assay, and she actually had panhypopituitarism. That explains why this patient, when she had the infection, the influenza, she deteriorated. Yeah, she had this extreme deterioration, and then things started to improve with control of the infection and giving her steroids and levothyroxine. And she was successfully discharged a few days later. It was a success story, but it was like a very bad time for us in the ITU at that time. So do you have any comments or ideas or questions at this point?
No, thank you. It's an interesting one.
Yeah, it was really interesting. Yeah. Anyone else?
No, it's really interesting because you would expect that she should have been symptomatic with influenza before the shock state. But maybe because her pituitary function was already on the edge, so she started manifesting a failing pituitary with a background of influenza A, which nobody can pick. It's really tricky to diagnose, but yeah, well done.
Exactly.
Sorry, excuse me. So if she had already a pituitary adenoma excised, and where is this part in the past medical history of the patient? Why no one reported this to you?
Yeah, this is a very important question. Actually, this patient had she lived alone. She didn't have any close relatives or first-degree relatives. Those people who brought her to hospital were not very close relatives, so they didn't know about her actual history. And unfortunately, this case was not in the UK. It was abroad, and there is no documentation system. So this information, this piece of information, wasn't known till the patient told us herself here.
Oh, okay. Yeah, she's
Yeah.
Rare presentation and difficult case.
Exactly. Yeah, it was a very good one to consider, like in any future case as well. Any other comments?
No, I just want to thank you very much for sharing this with us. It's a very good point about how to approach a patient who has shock and exhaust the whole means to find the source of shock rather than jumping into conclusion and carry on for a treatment that you know that it will fail. So if she didn't have pituitary replacement, she probably would have been died. But yeah, well done.
Exactly. Yeah. Thank you. So I have some clinical pearls to share, and if anyone also wants to add more clinical pearls, then of course he's more than welcome. So first, as I already mentioned in response to the question by Dr. James, don't solely rely on given history, because sometimes this history may be distorted, may be misled, may be anything. Sometimes even there is no history at all. So yeah, don't make given history the only source of information that you rely upon. Also, this one is really important. Supportive care is most of the time the backbone of everything, every piece of care that you give. Sometimes we don't have any diagnosis. Sometimes we don't have a sure diagnosis. But there are points of care that are given to anyone, like just giving oxygen, ventilating the patient on time, putting the patient on vasopressors, and then if no response, starting hydrocortisone, and so on. So following protocols of supportive care is very important, and sometimes more important than definitive treatment as well. The third point, this point actually is like, it may be controversial. a lot of clinicians screen for thyroid dysfunction with TSH, but sometimes TSH alone will totally mislead you, as in this case. In both times TSH was normal, and this would be the case in any central hypothyroidism. And also, actually, some patients with primary hypothyroidism as well will have normal TSH. They won't have a high TSH. It's something like dependent on experience alone, but they say that any patient more than 65 or patient presenting with atypical presentation, then you should screen with a full thyroid profile, not with TSH alone, as in this patient. Another one is that not all hypothyroid patients are hypothermic or euthermic, as we already know. So this patient had fever, high-grade fever actually, and she was hypothyroid. Also, that some simple measures make a lot of difference, like a medication alert or bracelets or some sort of documentation, like simple documentation, even a letter put in the patient's pocket or something like this. I mean, of course, I don't mean in the UK, I mean in areas where no formal documentation or official documentation is present. That would make a lot of difference. Then this is a very important point as well. So if you had your wide angle lens on, you would notice that the patient's heart rate was normal, and she was very hypotensive, and she was feverish. So this heart rate was improperly normal. This would lead you to the idea that this patient is either hypothyroid or that she is on a beta blocker or she had a heart block or something. So this was actually a good point to get from your clinical assessment. You don't need any labs to diagnose this at this point. Yeah, my last clinical pearl is don't be fooled by trends. So with this case and a lot of other cases, we were a lot of times led by the trend that's going around, like COVID, vaccine, anything, like any trend that's happening around. So don't be fooled by these trends. And that's it. These are my points. If anyone wants to add more, or anyone wants to argue with any of them, that's fine.
I just had one small thing to add. I'm not sure about the evidence behind it, but one of the lectures, I remember this lecture about panhypopituitarism, and he said the failing pituitary gland would fail from the least important hormone to the most important one, and probably because of that lady did still retain a bit of a thyroid function and a bit of steroid secretion as well. I mean, that would explain why she had almost a normal TSH while she was already failing, because sorry, I'm having hay fever. Probably have lost already the gonadotropins and the ADH and all of these non-life-saving hormones first. And when she became in a stress condition, she started to fail from the serious hormones, I mean the steroids and the thyroid function. So might be the case. But yeah, thank you very much for sharing that with us.
Yes, you're welcome, Glenn. Thank you. Like I may add a small comment on your comment as well. some theory behind the idea of adding the stress dose steroid in shock state, in septic shock, I mean. Some trial of like making this, giving us some sense to this, they theorized that a lot of patients have some sort of subclinical hypoadrenalism. And these patients can manage with their normal life and even with mild stresses, but when they are faced by severe stress, then they have like a manifest or an overt adrenal crisis. That's why these patients respond well to the steroids, so they won't respond only to the vasopressor. They need some steroid with it. That's why some of these patients may respond very profoundly to this very small dose of steroid. So this patient actually was like this. She was on very high dose vasopressor, and when she had the steroid, she responded very fast to this. Her shock state, I mean, improved very fast.
Thank you. Can I just stress on the point, your second point? I can see it's very important, and it was crucial here in this case. So best supportive care, most of the time, is the backbone of the care. I think, I just want to stress on this point, because here, best supportive care, although we didn't have a proper diagnosis, we didn't know what's going on. We keep like investigating things. I don't know what's going on, but what you did is supportive care just bought us some time till we get the list of the investigations and we got the rest of the results. We get the report. All those things was not picked up on the first time, but it's just supportive care. It bought you some time, few days, till you get the report, till you get the hormonal profile, then you get the proper diagnosis, then you start treatment. So actually, in this case, supportive care just for 2 days, it bought you the life of the patient.
Yes, you're true. Yeah, you're right. Yeah, actually, like our practice in the ITU in general is mainly dependent on supportive care, because a lot of times we have no clue what actually the patient has, and it's only supportive care. And sometimes even the patient may like be admitted to the ITU undiagnosed with a shock state and with maybe acute respiratory distress syndrome and multi-organ failure, and we do some supportive care, and then the patient gradually starts to improve, and we don't know what exactly was the diagnosis and why the patient improved, and we don't know anything, just the patient received some supportive care and was discharged, and that's it.
I agree. Yeah, sometimes you don't know what's going on, but at least because you've been doing the, I would say you'd call it like the A to E ITU. So you follow the protocols, you know that you need to give this and that, 1, 2, 3. You follow the full ITU protocol. Then maybe by one of them you fix the patient, but you didn't know that you're doing it.
Exactly. Yeah, you're right about this. Yeah.
Thank you.
Thank you. You're welcome. Any other comments or questions?
No comments. So I think this will conclude our session for this evening. Thanks everyone for your attendance, and it was a very interesting case and open discussion, brainstorming. I hope you enjoyed that. I honestly did enjoy that. I'm very happy. It was happy ending the patient's life, and we got the diagnosis. If you please, after the session, fill the feedback forms, and that will be it. Thank you very much.
Thank you. Thank you for all. Yeah.
Thanks.
Thank you.
Thank you.
Bye.
Bye.